To welcome you all this morning and wholeheartedly welcome Dr. Bughrara, who is coming to us today from New York, from Albany Medical College in New York, where he is currently the Vice Chair of Education and Professor of Anesthesiology. He's the Director of Anesthesia Critical Care Division and also the Director of the Critical Care Echo Program. Now, Dr. Bughrara and I have known each other for a long time. He did his critical care fellowship training at Johns Hopkins University and is an international expert in point of care ultrasound. We're so excited to have him give us this presentation today. I know that you are going to love it and learn a lot that you'll be able to take away into your practices. Nibras, thank you so much, and I'll hand it over to you.
Thank you so much, Sarah, for the invitation. And it's been a while since we talked last year. So today I will be sharing our experience here in Albany Med with COVID-19 cases, how we responded to it. So I'll be sharing a couple of cases that I took care of in April 6th, between April 6th and 14th. I have no disclosures, so let's start. Objectives, we'll be talking about the hemodynamic abnormalities associated with COVID and talk a little bit about the EAsY POCUS protocol, and then share case series of POCUS patient that received this exam in the ICU during 2020. So in 2020, we got swamped with COVID. We had at one point 79 patients in the ICU on late March, and the majority of them were really very sick. So as the anesthesiologist, as the anesthesia department, we closed the operating rooms, and then we deployed anesthesia teams to help managing these patients in the ICU. So we established a team that consists of an anesthesia critical care attending, trained in critical care. And we have residents who are, at that time, we implemented a first year anesthesia residents and surgical residents as well. And we tried to create a team. We created actually multiple teams to take care of these patients because the medical ICU was overwhelmed. This is just it looks crazy and very busy, but pathophysiology of COVID is basically a what really gets us with COVID is the dysregulated immune response to the virus that basically starts sepsis and will lead to cardiac and pulmonary dysfunction, mainly AKI and other system dysfunction. So after COVID, and day 5, after exposure, you might get a little bit of lung infection. But by day 10, the host response becomes really crazy. And these sick patients will get into hyperinflammation state. And frequently that affect the lungs and the heart. So how the heart affected? Basically, there are two kinds. They're both ARDS kind of variants. So you have this hyper crazy response to the infection. So the immune goes and produce all these interleukins 1, 10, 6, and tumor necrotic factors. And that lead to first transudative effusion. So as you see here to the right, the alveoli gets filled with mucousy, exudative stuff, and lots of atelectasis. So you'll end up with a lung that is very stiff, very heavy, and difficult to ventilate with low compliance. And we call this the H phenotypes. But also, you can have a phenotype where the majority of the problem happens with microthrombi due to the hypercoagulable state. So these patients will have very nice compliant lungs, but also severely hypoxic. Now, with the hyperinflammatory response, a lot of these will cause cardiac injury. So you'll end up with some positive cardiac markers, arrhythmias, the thromboembolic phenomena can get acute coronary syndrome. You can have heart failure with reserve ejection fraction, so diastolic dysfunction. Many things can affect the heart. And this is what we didn't know, but early in March, but we're started to learning as we go. So to review the mechanism of sepsis, that crazy dysregulated immune response will cause capillary leak. So initially, the patients will have decreased intravascular volume, which is basically just hypovolemia. Also, there's increased vasodilation, so they'll get into decreased systolic, decreased mean arterial pressure because of the decrease SVR, and also that will increase the capacitance of the venous system. So you'll end up having to fill a bigger, like a place or bigger cup with the circulation. So this leads to relative hypovolemia. So a bunch of hypovolemias. Also, the direct effect of the heart, you can have Takotsubo, you can have basically myocardial dysfunction, and that could affect both the LV and the RV. But also, increased pulmonary vascular resistance will lead to increase in the resistance, so that will cause a lot of pressure on the right side and cause isolated RV dysfunction sometimes. And obviously, a lot of them will have tachyarrhythmias and sinus tachycardia and AFib. So this is the pathophysiology of hemodynamics in general. Now, for COVID patients, if they have positive troponin or they have any cardiovascular involvement signs, the mortality goes up to almost 69.5%. So circulatory failure in COVID, again, could be due to hypovolemia or vasodilation or obstructive physiology, like, for instance, the acute on chronic cor pulmonale, or it could be a pump failure. Also, there could be an underlying cardiovascular disease. And a lot of times you have this complex shock status where you have a lot of these factors together, playing together, and you have a complex shock. The treatment, if there is hypovolemia, you need to optimize volume, give volume. And most of them will have SVR problems, systemic vascular resistance, so you can give vasopressors. And when you have pump failure, you need to give inotropes. Surviving sepsis guidelines in 2008 showed that standardization of care through guidelines would lead to basically improved outcome. And the first 1 hour bundle basically focused on measuring lactate, getting blood cultures, give lots of fluid, which is in COVID patients, we'll see that this is probably not a good idea. And then keep the MAP above 65 by giving vasopressors and inotropes if needed. This is just the review of the 2021 shock guidelines. They recommend crystalloids first. They're favoring balanced crystalloids, use albumin. They recommend against starch and gelatin. So you can use albumin when needed. And then if that doesn't work, you can use norepinephrine or vasopressin as a vasoconstrictor. And you can use that at the same time when you give volume to keep the targeted MAP of 65. And then you can add vasopressin to the norepinephrine if you start requiring more dosage or adjusting dose. And then if all that fails, then you can add the inotrope. So as you see here, the current process relies a lot on guessing. Basically, recommendations talks about give fluid. If it doesn't work, give vasopressin. If it doesn't work, give inotrope. And ultrasound was not used because average clinician was not trained. So we went from echocardiography, which is very complicated, which is when Sarah did her cardiac anesthesia, she went through 1 year training where she learned all these views with transesophageal, transthoracic. So it's complicated. It takes a long time to do. But we noticed that if we apply the ultrasound 2 centimeters below the xiphoid process and utilize the liver to check, to transmit the ultrasound waves, this way you can cut through the heart on a long axis. You can see the pericardium, the left ventricle, left atrium, right ventricle. So you see all the chambers of the heart, and you see the septum. Now, if you rotate the probe 90 degrees toward the head, this way you can look at the inferior vena cava entering the right atrium. So now we have an idea about the preloading conditions of the right atrium and the heart. And this exam takes really less than a few minutes. Now, how we assess the subcostal view, we start from top to bottom. We just look for if there is any pericardial fluid, yes, no. If yes, then is it causing obstructive physiology like tamponade? We look at the RV size, which as you notice here, it's smaller than the LV. So the RV, first lesson, should be always smaller than the LV. And you see here, the septum is not bowed toward the LV, and then you can see the you can assess the left ventricular size and contractility. After that, you look at the inferior vena cava, where you can see if it's collapsible, small, or dilated. So here, septic shock patients, and these images are familiar to Sarah probably. I think I got it from one of your slides. So initially, you can see that these patients are hyperdynamic and the IVC is small. So these are hypovolemic patients. The same patient at that time was requiring pressors, received volume, but 6 hours later, still requiring pressor. And you can see now how the left ventricle is not contracting very well. The entire heart is not contracting very well. So you can see here the right ventricle this is the tricuspid annulus. It is really not moving longitudinally. Do you see my arrow? I hope so. And then you can, if I put my finger here in the middle of the ventricle, you can see that these these walls are not contracting and coming toward the center. The anterior mitral leaflet is not opening vigorously to touch the septum, so there isn't much of volume going from the left atrium to the left ventricle, and then the mitral annulus is not moving longitudinally. So based on this, I can tell you that this left ventricle is severely depressed, and the IVC here is plethoric. So these are two hypotensive patients. They are the same patient, 6 hours apart with sepsis, and the picture is very different, and the management must be different. So in 2020, we just looked at the phenotypes that you can see with the subcostal view, and we classified them into clusters. And we did this just to help train our residents. So to transfer knowledge, it's easier to show them images and pictures and then relay the findings. It's better than give lots of angles and numbers and views. So at that time, we had these phenotype cards available. And you can see here, cluster 1 is when the ventricular function is normal or hyperdynamic. And this usually, if the patient is septic and hypotensive, then we can explain hypotension, whether it's due to just decrease in preload, like in phenotype 1, or due to low SVR. And then also we detect patients who have chronic underlying disease, like good contractility, small chamber, but thick ventricle, which a lot of times indicate there's underlying chronic disease like hypertension or aortic stenosis. Now, cluster 2 is the pump failure. So when the left ventricle is not pumping well, is not squeezing well, then we can blame a lot of the hypotension due to this pump failure. And we classified into phenotypes 4 and 5, which is isolated left ventricular dysfunction or both right and left ventricular dysfunction. Now, in the reds here, cluster 3, this is where you have isolated RV dysfunction. And in this situation, when the RV size looks bigger than the LV, then we know that we have an RV dysfunction not caused by the left ventricle, but it's caused by pathology between these two chambers. That meaning that's due to probably increase into the pulmonary artery pressure sudden that the RV cannot tolerate. So now let's go over a few cases. This is phenotype 1 or hypovolemic patient. You can see here the chamber size is smaller. There is no pericardial effusion going from top. The tricuspid annulus is moving vigorously. The RV is smaller than the LV. And then the LV walls are coming toward the center, the arrow here, there's good contractility. So these are good ventricular function, and the ventricles seems to be empty. But if I do the IVC and I see that the IVC is collapsing almost 100% and it's small in size, then this most likely would represent hypovolemia. One exception is you want to make sure that the abdomen is soft and there's no increased intra-abdominal pressure. So for instance, gravid uterus, if it's on top of IVC, it could be a problem. That's not related to just fluid. And also abdominal hypertension or abdominal compartment syndrome can give you this flat IVC. So hyperdynamic small ventricles, flat IVC usually indicates hypovolemia. How we use it, for instance, here you have patient who's hyperdynamic with a small IVC, and you look at the upper lungs, you see these A lines in the upper lungs, which indicates there's more air than fluid. In this situation, it just tells me that there's no significant pulmonary edema. So if you give some volume, you'll end up by filling the ventricle, filling the IVC. If you give too much volume, you might end up with a lot of plethoric IVC and a lot of B lines. So these here lines that represent more fluid or tissue than air, and the as an artifact here on the when you apply the linear or any kind of probe, so you can see the pleural space here. These are the rib shadows, and as you see here, there's a lot of comet tails that indicates there's probably more tissue or fluid. So this, if you see these in both upper lungs with a plethoric IVC, I would say probably your patient is not fluid tolerant. This is just so you remember how it looks like. Looks like this fluid. Now, the problem to use this in COVID is these are the images from our COVID patients in the first week. The majority of them, whether they're dry or not, they have low pressure pulmonary edema. A lot of them will have a lot of B lines, even if they are dry. And one of the first cases we went to, the patient was on infusion of diuretic because of wet chest X-ray. And when we did the ultrasound, we saw that the picture was really the opposite. Okay. Now, the way we implement this in the ICU, I usually time my residents and fellows during rounds. They have to do the exam in less than 3 minutes. So you can see that I do start the timing. And this is one of our fellows before COVID in 2019 doing his ultrasound, looking at the IVC, then the aorta. He saw the 4 chambers. There was good contractility. This is subcostal short axis view. You can see how the left ventricle is squeezing well. And then he would look at the upper lungs to look for pulmonary edema. So this is kind of like very quick screening method. Here, there's A line and maybe one B line in the other lung. So, and the patient was hypotensive. He has a normal exam. Based on this, we thought this would be a vasodilatory cause of hypotension. So we gave 500 bolus of fluid, and then we started norepinephrine. Now, this is an example of pump failure. You can see here, this patient has dilated ventricles. There's trivial pericardial effusion. This is the RV. It's not bigger than the LV. The LV now, if you see the walls are not coming toward the center, they're not hugging the arrow in between. Here, the anterior mitral leaflet is not opening vigorously, and the mitral annulus is not moving longitudinally very vigorously. So this is a severe left ventricular dysfunction. And when we looked at the IVC, you can see here the IVC is dilated with no significant ventilatory change in size with the respiration. And below here, you can see there is also some pleural effusion. So, and if you put the ultrasound on the upper lungs, if they are in CHF decompensation, you can see pulmonary edema or B lines. So just to go quickly over assessment of the left ventricle, you need to ask yourself a few questions. Number one, are the walls getting thick and moving toward the center? Is the mitral annulus moving vigorously here on the bottom? And then is the anterior mitral leaflet is hitting the septum? So if you cover these three, then you can do a good assessment of the left ventricular function. Here, this is, I know this is a normal because he's one of our residents. He donated to his body to scan, and this is his heart. It's normal. If we compare this to the image here at the bottom, you can see that the ventricular walls are not thickening. They're not coming toward the center. The anterior mitral leaflet is really distant. It's not opening vigorously. It's not touching the septum. And then here at the bottom, the mitral annulus is not moving longitudinally. So visually, by looking at comparing, you can see here this left ventricle have normal function on the top, and here the left ventricle is has poor function at the bottom. Now we're moving to describe the isolated right ventricular dysfunction. So anytime the RV is bigger than the LV, we have a problem. Like here, this is a huge RV. You see the septum is wiggling toward the LV. The LV is smaller in cavity. So this is a cor pulmonale if your patient is hypotensive and the IVC is plethoric. Now the right atrial enlargement happens over time. So when you see right atrial enlargement, that usually indicate chronicity. And so right atrial enlargement, right ventricular hypertrophy, these two will indicate chronicity. And when we see them, we can say that this patient has probably some pulmonary hypertension, chronic, and now he's having acute on chronic cor pulmonale. So when you see very thick right ventricle dilated or enlarged right atrium, usually you look for, you ask the patient and you try to see if they have COPD, sleep apnea, chronic thromboembolic disease. You look for a cause for it. All right, so I have a question for you. Is this patient hypovolemic? I don't see the chat here, but no, I have my residents here. I have two residents, one doing the advanced CQ POCUS rotation and the other one's doing the PACU POCUS rotation. So they say no, but I think you spoke too fast. Look at this IVC and tell me, what do you think? So is this patient hypovolemic?
Yes.
He is, great. So this patient has was the initial diagnosis by looking at just this single view of the heart, cardiogenic shock. So the recommendation was minimize fluid, started in epinephrine. This was done in the emergency department. The condition got worse. Then the chart review showed that the baseline ejection fraction was less than 30%. And the blood cultures came back positive, not the cultures, but the smear, the examination showed that there's MSSA in the blood. And so this patient is septic and he needs fluid, and he received the right treatment. He received fluid rather than just inotrope. So that leads me to the underlying chronic disease. So if your heart starts dilated like this, it's very difficult to determine easily that if this ventricle is empty or not, or does this patient have hypovolemic or not. For this reason, anytime you assess volume, you need to really look for and understand the underlying chronic disease, and then also you need to examine more than one system. Like you look at the inferior vena cava to see the preload conditions, and anytime you see signs of chronic disease, then you will need to do more critical care echocardiography. You need to do some quantitative assessment. And Sarah just published a protocol called the STARS protocol. And basically, this protocol basically looks at if we do a screening of one view or EAsY exam, and then anytime we see signs of chronic disease, then we start doing some quantitative assessment. So again, if you have pre-existing disease and sepsis, that can produce very, very complex and confusing hemodynamics. And when we design the phenotypes, we can basically see markers or phenotypes that associated with chronic disease, and that usually prompts more digging into history, and that basically gets the ball rolling into getting critical care echocardiography with measurements. So now for volume assessment, of course, that patient that I showed you earlier with the dilated left ventricle that's not squeezing and flat IVC, I wouldn't give 30 mLs per kilogram IV fluid. I would give fluid a little bit more carefully and reassess. So I'd give 5 ml per kilogram challenge and then reassess. This way, I'm careful. I'm not overloading that patient with volume. And as you see here, just by screening, you can actually start focusing your management. So instead of giving one size fit all, start fluid and inotrope, and vasopressin and inotrope, now you can see how you can focus your tailor your management. Also, I want to show you here that the pulse pressure variation is not accurate, because it would be positive in patients who are hypovolemic or volume overloaded if they have right ventricular dysfunction. I don't see the chat. I see there's few messages, but we'll get to these later. They're not visible on my screen, sorry. So clinical integration. Point of care ultrasound, we need to go back to the basics, and I love the IAM framework. You always, if you have a question that you need the answer right now and you cannot get an expert to do the examination, then like, is my patient hypotensive? Why? Is my patient dry? Why is my patient in acute respiratory failure? Then you need to do point of care ultrasound. And you need to think, how can I get the best information? So for instance, you can start by examining the heart, take a representative sample, one image, but then you have to do more systems, including the IVC and the lungs. And then you need to assess the image quality, recognize structure, and then it's very important to start looking at patterns, and that's where the phenotypes comes. Now, once you have this interpretation, if you do them correctly, then you apply your management. You start you relay the information you got to the patient. So it's very important that you understand the underlying hemodynamics when you apply the management. What I'm trying to say here, I can train anyone to do the subcostal examination in one day, but interpretation and clinical decision-making requires a lot of knowledge, requires a lot of training, and usually you need a physician who understands what's going on. So training the interpretation medical decision takes some time. So how we do this in Albany? We basically, anytime we do an exam, we save the images and we save patients' information. And because our residents are busy, and if I ask them to put the number on just typing it in, it might take time and they might not do it. So we have scanners in all ultrasound machines. All you need to do is scan the patient name or medical record number, and scan yourself, and you're ready to go. Just need to write the indication. Then we'll go to the acquisition. So we basically separated the acquisition phase from interpretation. So this is one of then medical students. Now she's one of our residents.
Ingrid, INGRID.
Subcostal for chamber view. Then looking at the IVC.
Show me the aorta.
Then seeing the aorta. Make sure that we saw first the IVC. Then we added something called subcostal short axis view. So I can look at the heart from the short axis, from the subcostal area.
Start with the left.
And then here you look for the upper lungs for B line, A line pattern. And a lot of places we look at the pleural spaces as well. And this shouldn't take a lot of time. Now, after performing the examination and saving the images, we go to interpretation outside the patient.
Pericardial effusion that we could see. The right ventricular cavity was normal in size.
Mhm.
Good contractility. normal septum. Left ventricular cavity was normal in size, but there was hypertrophy. We had very good image quality. So this would probably be closer to a phenotype 3, the left ventricular hypertrophy. We also had the plethoric IVC, and then we had definitely a lot of B lines on the lung exam.
So you see here, we comment on the image quality first. Then we go systematic from top to bottom. We'll look at the pericardium, the left ventricle, cavity size, wall thickness. Sorry, the right ventricle first because it's in top. Thickness, size, contractility. Then we'll look at the septal thickness and position. Then we'll look at the left ventricular size and function. And then we comment on the inferior vena cava. So I'm going to share with you a few cases that we did in April. What we did in April, we took the residents who are starting the rotation. We have some recorded videos for how to use the subcostal view, phenotypes, and we had our residents review these videos in the classroom without instructor. And then after they're done with the videos, the instructor will come in, and then we'll do some cases quickly to explain the phenotypes concept. So they get, and then after that in the afternoon, we go to the ICU, surgical ICU, where they scan 10 patients that have no COVID with supervision. So we train the entire team over one day before their rotation next day. And then during the days of that we took care of these patients, the residents will go and will scan the patients pre-rounds, and then during rounds we discuss the images, and then I go and examine the patient if needed, if the images are not good in quality or if there are signs of chronic disease. So this represented the 14 patients we saw over these 10-day period or 12-day period. 100% had ARDS. More than 60% of them were prone. We had 7% on ECMO. 60% of them had circulatory failure, a lot of acute kidney injuries, multiple organ dysfunction. It's septic shock. And we figured that managing the ventilator required an expert, and managing volume status and circulatory failure required an expert, but the interventions are volume optimization, vasopressors, and inotropes. If we have a good examination at bedside, these decisions could be done later during rounds. So this is an example. The residents cover the probe so it doesn't get infected with just plastic cover. Doesn't have to be sterile. Then get the protective gear based on the hospital policies. And then this is in the morning before rounds. The resident will go in, will examine the patient. This patient was hypotensive. So subcostal view, can see both ventricles are squeezing well. So it's not a pump failure. They seem maybe empty, but then when we look at the inferior vena cava was very plethoric. And that patient was not on a lot of PEEP. Then this is the aorta to differentiate and make sure that we looked at first the IVC. And then now looking at the upper lungs, tons of B lines. So from here, we know that this patient has distributive shock, and probably volume might not be very good idea. We started norepinephrine, and we obtained the map again. So here you can see that the time consumed for the exam from entering the room and finishing the exam is less than 5 minutes. And this was done after 1 day of training. So in the morning, this is one of our residents sending me a text about the phenotypes. So from here, for instance, in the patient D332, his phenotype is 2, so vasodilatory, and he's hypotensive. But look at the next patient has phenotype 6. That means now the RV is dilated, and maybe this patient needs more attention and quicker attention. So we start rounds and with the patient with the newly dilated RV. Obviously, we want to make sure that we don't transmit the disease outside, pathology outside. So you notice here, left side, left hand to scan the patient, right hand to handle the machine. There's a specific way we deglove the probe so we don't touch ever the machine with the soiled hands. Then change gloves, then do cavity wiping inside. And when they leave, we do another cavity wipe outside. So this was done in the morning before rounds. Each resident covered 3 patients. So this is the data we have. These are the 14 patients. I needed to go inside the room and examine the patient based on either inadequate images or signs of chronic disease only 13% of the time. And 87% of the time, the images were good for us to do rounds. And that helped save my time and save a lot of equipment or protective equipment use. So now I'm going to share with you some of these cases. 50-year-old with history of diabetes, COVID-19, had positive troponin, ARDS with PF ratio 110, was hypotensive at the time, and not making any urine. And he received 2 liters in the last 24 hours on norepinephrine, vasopressin, and lactates 4. So what do you think from this? Do you think we need to stop fluids, start inotrope? I mean, he got 2 liters in the last 24 hours. Yeah, shall we give inotrope? I see my resident said no. Let's start ultrasounding. So the chest X-ray looked very wet, and this is the lung ultrasound. Lots of B lines in both upper lungs. Now, subcostal view, going from top to bottom, there's some pericardial fat pad, maybe some pericardial fusion. And then this is the RV, squeezing well. This is the LV, seems empty, hyperdynamic. The muscles are almost kissing. So could be hypovolemia, I don't know, or obstructive. Now you look at the IVC, and it's really small. So we went with a hypovolemic shock, and I was wondering how come the patient just got 2 liters of fluid. Then while we were looking at the aorta, we found this on top of the aorta. That's the gastric area, antrum. And we placed an NG tube, 1.8 liter came out. So this patient had ileus, and all the fluid we're giving is just being third spacing. Now, we gave 500 boluses multiple times. We ended up with a good, and we were monitoring the IVC the entire time, and we were able to get to treat the hypotension. So the map restored with volume, and the patient now lactates went down and off pressor. And so another case, 50-year-old transferred from New York City. At that time, New York City hospitals ran out of oxygen. So we received a lot of transfers with the helicopter. And it was very traumatic because some of these patients were having chest compressions on the elevators coming from the helicopter. It was bad. This patient again has positive troponin, and in the pre-round assessment, this is the examination. Ventricles looks like full, but good contractility. This is subcostal. This is the subcostal short axis view, just to look at the mid-papillary muscle of the left ventricle. You see that it's squeezing well. The RV is kind of enlarged, but there's no septal shift toward the LV. And the IVC was full, and he has bilateral, or she has bilateral B lines. So here, this patient is vasodilatory, and probably we shouldn't be giving fluid to her. And then few days later, now with being not giving any fluid, the IVC starts to be collapsible instead of just plethoric and normal in size. And then this patient did very well. Before we extubated her, we gave Lasix, and we followed the IVC. We looked at the lungs before extubation. And now here on the image of the lung to the right side, you see that the A line starts to appear. We still have some B lines, but there's some A line as well. Anyways, she passed the extubation criteria. She has a good RESP, and we extubated her, and she stayed extubated. So that gave me the ultrasound here, gave me confidence that we optimized the volume before extubation. All right. 65-year-old transfer, another transfer from New York City, COVID-19. He has ARDS. He has 1 liter positive in the last 24 hours. And he was anuric and on Bumix infusion, placed by the nephrologist. Chest X-ray looked very wet. So we do the subcostal 4-chamber. You see here the ventricles are contracting well with the subcostal short axis. There's almost obliteration of the left ventricular cavity. It's really small and the chambers are small and hyperdynamic. And then we look at the IVC, it's flat. And the lungs, of course, has lots of B lines, which is a low pressure pulmonary edema. So that patient who was on infusion of diuretics, the nephrologist was trying to treat low pressure pulmonary edema with diuresis, which did not help. So we gave some fluid. This is the IVC after 500 bolus times 2. Now it's becoming normal in size. And now after that 1 liter, we notice that the RV becomes dilated. It's bigger than the LV. And this was the patient that pre-round, if you remember, the residents saw new RV dilation. So, and the IVC was plethoric on that day. I think it was day 7 or B lines, both upper lungs. So now we started the Bumix on day 7, and we proned the patient, and we're off norepinephrine after that. Okay, here's another case. 75-year-old, morbidly obese, hypertensive with AFib, COVID-19, PF ratio 154. She was proned, PEEP was 10. She has acute kidney injury on continuous renal replacement therapy, and she was hypotensive. This is the subcostal 4-chamber. I can tell you here, and notice that the ventricle is thick, the left ventricle, no pericardial effusion, good contractility, just based on the phenotype. The IVC looks collapsible, not dilated. This is the aorta, just to show you, they look very similar to the IVC. We always get the aorta. And the upper lungs show AB pattern. Now, because of the thickness of the LV, I had to don and then go to the room and do critical care echocardiography. We discovered that there's some LVOT dynamic obstruction based on continuous Doppler. And despite the IVC not super empty, we still gave volume and phenylephrine. And we're able to improve the map. So this is basically the this patient had SAM also. You can see the anterior mitral leaflet was being sucked in from this turbulent flow in the left ventricular outflow tract. And with the M mode, you see hyperdynamic LV, and the IVC was plethoric because of the obstructive physiology, not because of hypervolemia. One more case, 45-year-old COVID-19, ARDS, AKI, chronic kidney disease, coronary artery disease, diabetic, asthmatic. MAP was 50, received some fluid with no improvement. This is the subcostal. You don't need to be an expert to see that the ventricular walls are not contracting well. So the LV really is not squeezing. IVC is plethoric. B lines, but of both lungs. So fluid is not the answer here, but this patient needs some critical care echocardiography to look at some numbers, like E over E prime, and then we started norepinephrine, epinephrine, and we have improvements. So these are hemodynamic management cards that we included in each machine that helps guide management kind of, and it's more for discussions during rounds. As I said, the training for residents was happening during the entire 2 weeks or entire month of their rotation. We still have time for a few more cases. So COVID-19, ARDS, AKI has positive troponin, low MAP. This is subcostal. And you can see from top to bottom, no pericardial effusion. RV is contracting well. LV is maybe contracting well, but I notice here there's calcification, severe calcification, and the aortic valve is not moving. So the IVC was not flat, but since this patient has signs of chronic disease, we went in and I did some critical care echocardiography and measurements, and we discovered that this patient has severe aortic stenosis, and we optimized volume based on diastology. E over E prime was low. We gave 250 times 2 of fluid, and then we reached E over E prime of 10. So we utilized a lot of, this patient requires a lot more care. I had to personally go and do the ultrasound. 55-year-old diabetic hypertensive, PF ratio 130, anuric. All right, Max, what do you think is going on? Yeah, the RV is very dilated and plethoric IVC. And this is the aorta, just to prove to you that they look very similar. You need to, when you examine the IVC, you have to save the image and then save the aorta as well. And B line, yeah. So treatment for this patient is something that doesn't cause further pulmonary hypertension. Optimize the ventilator setting, maybe prone the patient, start vasopressin, and required to add epinephrine. And we started volume removal. Very distinct and different from the previous cases. Here, management card again that we talk and discuss during rounds to make sure that we cover management of patients with acute and chronic cor pulmonale. Another case, 70-year-old, COVID-19, PF ratio also 140, dropped suddenly to 85. And the patient was on pressure support ventilation and pulling good tidal volume. So the mechanics didn't really support worsening ARDS H type. So again, we did ultrasounds. RV is dilated, working fine. IVC is full, but patients struggling with breathing, you can see that the collapsibility of that IVC is related to the struggle of the patient trying to breathe. And there were like A line in one side, B line in the other side. But here, because of the mechanics, we thought, could it be PE? So we looked at the femoral veins, and this patient has bilateral occlusive DVTs. So started in therapeutic dose of low molecular weight heparin. So again, we only scanned the veins because there's acute RV. We were thinking this could be a PE. We didn't want to send the patient to get a scan. We said, well, maybe if there's a DVT, then treatment is going to be the same. And yes. That day, we scanned those patients. And in this row, the first 2 patients had DVTs. and the last patient had a stroke. So we learned early on that COVID was associated with hypercoagulable state. This is one of the patients. This is one of the microthromboangiopathy disease caused by COVID, because this is not, he was not on high dose pressors. This is just, at this time, we thought it's weird. And we started putting patients on low molecular weight heparin, or actually heparin infusion if they are super sick, because we thought it could be related to hypercoagulable state. At that time, we really didn't know. We're learning as we're going. Finally, one more case. This patient had asystole CPR with ROSC. Just want to show you that even for these patients.
We are no longer, I got shut.
Move it.
Shut that down.
And then to the left again until you see the tip of the catheter.
So
Yeah,
the,
that's perfect. Record that. Yeah, that's what you wanna. That confirms the tip of the catheter.
so confirming of
So the RV goes subcostal long axis again.
the reason why we're doing this, the cardiologist wasn't available to do the echo, and after ECMO, we just wanted to make sure
For that,
the surgeon
I'll need to.
wants to make sure that the RV is offloaded and that the placement of the ECMO is correct. And you can see that we were able to provide this information. We also provide information about the RV function based on simple subcostal. So by the time the echo tech came in to do the ultrasound, the surgeon already left, and we already know the information we need to know. So I'll end here to get some questions. And we published our experience. It's open access. It's published in Critical Care Explorations. So if you want to read it, review it, yeah, be my guest. And yeah, let's take some time for question. We have probably 7 or 8 minutes left.
Dr. Bughrara, thank you so much. What an amazing talk and an amazing application of point of care ultrasound to a very sick patient population. We were definitely in discovery mode at the time. This is just kind of so cool to see how you were able to apply it. I just wanted to see if anybody had any questions. As a reference, in the chat, I included some of the articles that Dr. Bughrara had referenced, the publication that he had on the subcostal only when compared to the focus TTE, which is kind of the more 6 windows, the 6 views of a more focused cardiac echocardiogram. And then I also put in the STARS protocol, which he mentioned as well in the chat. Does anyone have any questions for Dr. Bughrara? I hear EAsY, excellent talk. Thank you. Thanks. This was very informative. I think, you know, one thing that I just want to highlight, and maybe Dr. Bughrara, you can kind of speak on your experience here, is in most of these cases, I would say the majority, it seemed like you got the information you needed from the EAsY exam, from the subcostal and IVC. There were a handful where you had mentioned there was chronic disease or some underlying cardiac pathology that moved you forward to do kind of a more comprehensive exam. Can you share with the group what you found in your study when you compared kind of the EAsY exam as a single view compared to kind of a more views for diagnosing different kinds of shock? Was that also what you saw in your study?
So yes, so remember we did this study on medical ICU population. So I would say that we were able to get more views than on the surgical population, where a lot of these patients had some issues, some surgical wounds in the abdomen. In the past, in the study, when we compared the EAsY to the full fate exam, we really missed 2 big cases, actionable pathologies. One of them was with the subcostal view. We saw only the base of the heart, which was hyperdynamic, and we missed severe Takotsubo because we couldn't see the body and the apex. For this, what we did is we added the subcostal short axis view to kind of help more assessing the LV, And we found that we can see it in around 60% of the patients. The other thing that we noticed that we missed one big case of RV dilation because with a subcostal view, you tend to underestimate the RV size because of the plane. So if you apply this and use a plane that's not correct, then you can underestimate. You don't usually overestimate, but you underestimate the RV size. So we, during that big 102 cases study, that Sarah shared with you, we also missed RV dilation. But in this group, we basically, because we did the assessment together as a team, so it wasn't the residents who doing the reading, it was the attending physician. We did not miss anything in these 14 patients. We just learned that what we did was enough or what we did needs more assessment. For instance, if you see signs of chronic disease, then you know that we need to do full critical care echocardiography. So in this case, there was only one patient that we couldn't get views on. The rest of the 13 were getting views every day, and in majority of patients, we have adequate views. Now, some of them had very poor views, and I really caution about trying to do interpretation for anything that's not adequate.
Yeah, that is so true. And really thank you so much for sharing those cases that you had highlighted there. Because I think that we've all seen that, right? That you have a patient who has some sort of underlying pathology, and what becomes very challenging is volume assessment in those patients. And that's when doing that full exam, like you showed with the diastology and all those things, becomes really important. So I think part of this is understanding that in general, it's very broadly applicable and can really help you manage the patients. But sometimes you just need a little bit more information. And if there's underlying disease process, cardiac disease processes, those are typically the times. And yeah, and that's another really good point that you make, Dr. Bughrara, that the subcostal view oftentimes underestimates the RV size. The way I like to think about that is that if the RV is big and you've got a nice, beautiful open subcostal view, in the subcostal view, then you know something's up with the right ventricle, right? Because typically it should be pretty small.
Correct. I want to say that this really helped me during that time, the screening, because the screening was done with our residents after 1 day of training. So instead of me trying to guess who would need a full echo or full assessment, it really targeted my efforts. So instead of just doing it, I knew exactly out of my 10 patients during the day, like which ones that will need me the most. And I thought this is one of the real main reasons why we implemented it. And I really we're working on a multi-center study now to see how this is applicable in different units. And the key is you can get a good scan, but do not do the interpretation on your own. You need to have someone to help you with the interpretation, and you need to save the images. So for quality assurance, these are very important. You cannot simplify image acquisition and not do the due diligence of doing quality assurance and learning about the limitations of this. And you cannot do this without the system where you can actually save all your images and then review them with an expert.
Thank you so much, Dr. Bughrara. We're so fortunate that you were able to take time out of your busy schedule to give us this talk this morning. We're grateful to have you yet again as part of the Global POCUS Collaborative. Thank you to your residents for sharing you with us this morning. And we'll make sure to publish this presentation on our YouTube channel online so that you all can go back and review it. And also see all of the articles that Dr. Bughrara has referenced in his talk. Thank you so much, everybody. I hope you have a wonderful Wednesday.
Thank you, and hopefully see you soon.
See you soon. Bye.